So hi all, I'm sure you guys are able to hear me at the back also. My name is Alok Pant. Most of you already know me. I'm a physician in internal medicine. The topic today, right there it is, thrombocytopenia in seriously ill patients. Thrombocytopenia is a very vast topic. It's not a small topic, and each one of the causes of thrombocytopenia is in itself a huge topic. So we'll focus, it's not working? Ow. My bad. But you could have, okay, is it better now? All right. Thrombocytopenia in seriously ill patients. I would be covering some aspects of thrombocytopenia which is commonly seen in patients who are either very critical, most of them in the ICU, in our case in step down. So I would just be focusing my attention to some common things which you as internists can identify in seriously critically ill settings, right? So let's start. So very common causes of thrombocytopenia. We should all know about them before calling for help. You know, as soon as we see thrombocytopenia, and if the patient is like critical in say in step down unit, the first thing we do is we pick up the phone and say, let's call a hem-onc consult on this patient. That's a reflex thing. You know, but before we even start all that, we have to focus on some things here. Remember, most of these patients are sick. They are very sick. So the normal homeostasis is disrupted in these patients. Platelets are in a continuous state of homeostasis. Production, sequestration, pooling, consumption, destruction. So at any given point of time, their number has to be pretty constant in a given individual. In seriously ill patients, one or more of these mechanisms is disrupted, and hence we see thrombocytopenia. Now we have to triage patients for appropriate treatment, because the underlying etiology will tell us what next needs to be done. It's very important. Say for example, there is an abrupt onset. We need to make a quick decision on what next needs to be done. We send the HIT immunoassay to a lab. When do we think we are going to get it back? We'll not get it back for at least 4 or 5 days, I think. You know, I think the best I have noticed here is 3 days. But it takes time, and we have to arrive at a quick decision. Now, the third thing, decide when to transfuse platelets. The evidence on this is very, very low, very weak, and I have researched a lot of articles and literature on this, but we don't have a very high strength evidence on when to transfuse platelets. Basically, it's based on our clinical judgment, you know, and the demanding situation. For example, a patient comes with severe bleed. We would like to transfuse right there and then, you know. If the patient is not actively bleeding and is clinically stable, we would like to find a cause before we initiate the transfusion. Platelet transfusion is a very high volume procedure. You know, for example, one platelet unit increases the platelet count by 15,000. With an ongoing critical illness, with consumption, with destruction and everything, we need much more than that. Most of our patients, you know, they come volume overloaded. They've got pulmonary edema. So we have to be very careful when we transfuse platelets to these patients. So this is common knowledge. You guys know what thrombocytopenia is, less than 150,000 per microliter. Severe thrombocytopenia is less than 50,000 per microliter. and, like I said, disturbance of balance, production, sequestration, and consumption. Now, the first thing when a patient comes to us is we see the lab values. We usually get all the lab values. We see that the platelet counts are low. Next thing we should focus on is our history and physical examination. We should try to find out what were the previous platelet counts on this patient. Has this patient been running chronically low platelet counts? Right? Is there a family history of bleeding disorders? Is the patient presenting with any petechiae, purpura, bruises? Has the patient previously presented like that? Now, in physical examination, we confirm all our findings. We look for lymphadenopathy. Suppose there is focal lymphadenopathy, we should be looking for a focal site of infection. Generalized lymphadenopathy, we should be looking at HIV, autoimmune causes, these kind of things. Labs, of course, you've noticed low platelet count, the patient is critically ill. Let's run a few labs, for example, let's find out if the patient has hepatitis C, if the patient has any autoimmune disease, based on a history and physical. Let's find out if the patient has HIV, because all these in a critically ill patient can cause thrombocytopenia. Now the prevalence, the studies, like I told you, they're best termed as fair studies. None of the studies is path-breaking or a game-changing study. There was a systematic review in which they studied, they did 24 observational studies were reviewed in that, and they found out that surgical ICU had slightly high prevalence of thrombocytopenia in the medical ICU. But they didn't take into account a lot of things in that, so I really don't know how much that is true. Sepsis is one thing which is the commonest thing, both in surgical ICU and medical ICU. Patients who have trauma and sepsis, they carry the worst prognosis. Now 20 to 30% have thrombocytopenia already on arrival, because patients can come directly to ICU, or patients can be ill in the hospital and then they are transferred to ICU. In these cases, there is a possibility that the illness has already disrupted the thrombopoiesis, and the patient has presented itself, in the beginning only with thrombocytopenia. 20 to 30% they develop afterwards, and 5 to 20% of them are critically ill. They have got severe thrombocytopenia. Why is it important? Why is thrombocytopenia important? It correlates with a lot of things. It tells you what the prognosis is. There have been some studies which have shown that there is a common link to acute thrombocytopenia in critically ill patients and the length of ICU stay or the prognosis the patient carries. The more severe the thrombocytopenia is, the poorer the outcomes. Now, magnitude of thrombocytopenia. Now, if the patient is in medicine ward with liver disease, is already running a platelet count of about 30,000, comes to the ICU, count drops to 20,000. Is that more relevant? Or a patient who has presented and is doing perfectly fine, all of a sudden develops respiratory distress, severe sepsis, is rushed to the ICU, and his platelet counts have dropped from 250,000 to 50,000. So the second scenario, it's more important than the first one. There are some scores, like Apache and MOD scores. They are usually put into practice in the critical care settings. They did some studies and they found out that the degree of thrombocytopenia related directly to the higher scores. So the more severe the thrombocytopenia was, the higher the score on these scoring systems. thrombocytopenia, we can transfuse platelets. So there is an intervention we can do. It's very important that we recognize whether we need to transfuse the platelets, we need to wait, we need to start the patient on IVIG, we need to give prednisone. It all depends on how quickly we are able to identify the exact or the near exact cause of thrombocytopenia. Let's start with a case here. I've got a few cases here. Case 1, here's a 67-year-old male patient who presented with acute coronary syndrome, had an emergency percutaneous intervention, was started on unfractionated heparin, aspirin, Plavix, aptifipatide. That's a G2B3A inhibitor. 6 hours later, the patient's platelet count dropped from 270,000 to just 6,000. The patient shows no bleeding, clinically very stable after the PCI, no hematoma, stable patient. So what should we do next? So should we stop heparin? See the question once again. 6 hours, 270,000 to 6,000. Can it happen with heparin? Yes, it can, but only if the patient has been pre-sensitized to heparin within the last 30 to 40 days. Yes, it can happen, but I don't even know if the magnitude is going to be that severe. Antiplatelet agents be stopped. The patient already has 6,000, platelet count is 6,000. Do we need to give these patients antiplatelet medications? This is a question we need to ask. The threshold, the only moderate strength evidence we have for transfusion of platelets is platelets less than 10,000. The platelet count here is 6,000. So should we transfuse platelets to this patient? The last thing, the patient is clinically very stable. He is not showing any signs of bleeding. He's perfectly fine. So let's order a peripheral blood smear. This is the peripheral blood smear. Now if you would see this smear here, right there where the arrow is, this is called clumping, seen in pseudo thrombocytopenia. Where do we encounter pseudo thrombocytopenia? So we have taken a sample and we have put the sample in an EDTA bottle. What does the EDTA do? It causes calcium chelation of M antibodies on the platelets, which are directed against the GP2A3B receptors, and they cause clumping. So what should we do next? It's a lab artifact. EDTA is the usual culprit, but for example, if a patient is on a aptifipatide and we do, the patient presents with pseudothrombocytopenia. We send the patient's blood in a citrated sample. The patient still shows thrombocytopenia. This is a caveat. We have to remember that in patients who are on aptifipatide can have clumping even with citrated samples. Then we should send a heparinized sample in these patients. We need to rule this out before any therapy because the patient is normal. The patient doesn't even need to be in the ICU. Let's go to the second case here. 60-year-old patient who has got multiple myeloma. He received bortezomib, dexamethasone. A few days back, presents with fever, shivering, and shock. Physical examination is completely unremarkable other than the fever, and the shock the patient has, unstable vitals. The only physical examination finding is an old blunt hand trauma of the right hand. Procalcitonin is 223, INR is 1.7. Activated partial thromboplastin time slightly elevated. The patient is in renal failure. Platelet count is 48,000. So what are we thinking here? Is it multiple myeloma? It can be. Multiple myeloma can decrease the production, but this platelet count decrease has been fairly progressive. So it could be multiple myeloma. Antineoplastic therapy, yes, the patient has been on antineoplastic therapy for a long time. It can cause bone marrow suppression. Sepsis, definitely. The patient has presented with circulatory shock here. The procalcitonin is very high. All the signs point towards sepsis. We do a workup for sepsis. We do radiological investigations which are completely unremarkable. We draw the blood cultures, but blood cultures take some time to come back, so we really don't know what's going on here. If you would remember that I told you that the patient had presented with a blunt hand trauma. That was the only physical finding on this patient. So this patient's sepsis was attributed to that blunt hand trauma, and that area was debrided by surgery. If you look at the pictures here, this is what they did on day 1, and this was later on. This was a secondary closure. So the patient presented, this is the platelet count, the solid line. Cytostatic therapy was started there. That's a prothrombin complex, fresh frozen plasma. 4 units were given. This is the patient's INR. It was high at the time of coming. The platelets dropped significantly on day 1, right there. Antibiotics were initiated here. Wound was debrided. Platelet count remained stable after that. It did not drop further. A mild increase here. And the secondary wound was closed. Antibiotics were used as targeted, and slowly the platelet count, it creeped back up. Sepsis-induced thrombocytopenia. Like I mentioned before, it's one of the commonest causes of thrombocytopenia in critically ill patients. Decreased production, yes. The patient, a patient is ill, he's not going to produce a lot of platelets, for sure. How? Marrow suppression. Consumption, how? By thrombin generation due to sepsis. Sequestration, how? By hemophagocytosis. So all these things are coming into play here, and they are indicating a dysregulated host response. This usually indicates a very poor prognosis. It indicates even a worse prognosis if the patient presents with shock. Let's go to case 3 here. 18-year-old female, she fell from the 4th floor. There was subarachnoid bleed, which was stable. There was hemopneumothorax, pelvic fracture. Patient presented with hemorrhagic shock. CT revealed active retroperitoneal bleed. Hemoglobin on presentation was 6, but platelet count was normal. The hemoglobin count had dropped from a normal hemoglobin to 6 within no time, so massive transfusion protocol was initiated. Massive transfusion protocol is usually initiated when the patient has lost twice the amount of the blood which a person usually carries. So platelets in 7 hours dropped from 270,000 to 51,000. Let's see here. So if you see here, these were the platelets on arrival, and they dropped to this amount after massive transfusion protocol was initiated. Packed red cells were given, fresh frozen plasma was given. Since fibrinogen is the first to go in critically ill patients, that was given in 10 grams. The patient received platelet concentrates, 10 units in this period. So what do you think happened here? Why did the platelets fall? Hemodilution. That could explain a lot of things here. The patient received a lot of volume. Trauma-induced thrombocytopenia. It's a common cause. trauma induces coagulopathy. We all know that, fibrinogen goes down. There is hemodilution because we are giving patient plenty of volume. It's an absolute indication for platelet transfusion. It's only a bridging measure. The active bleeding in such patients needs to be stopped, and that will only happen by intervention. So transfusion of platelets, it's a bridging measure till we actually control the bleeding the patient has. So there is weak evidence to suggest that in transfusion we should maintain, how much platelet count we should maintain in such patients. So maintain 50,000 in any trauma and maintain more than 100,000 in any bleed or traumatic brain injury. So that's a goal we should be looking at. There is a role of tranexamic acid in trauma. It's given, it's an antifibrinolytic. So it's given as early as possible. You really don't need to know that. 1 gram bolus followed by 1 gram over 8 hours. It reduces mortality. And this has got, the evidence is good in this. That's why I brought this slide up. A crash 2 trial. Case 4. 46-year-old male patient with ITP had a traumatic brain contusion after an accident. Admission platelet count was just 11,000. So patient has history of good response to IVIG as well as steroids. What should we do next? Now remember, this patient already has a chronic condition in which platelet counts are very low. Now he has suffered with a brain contusion and has previous good history of response to IVIG and steroids. They have not mentioned that the patient is actively bleeding. ITP. Let's talk a little about ITP here. So the onset of this condition is very rare. It's even rarer to have these patients come to us in a critical condition because in itself the condition is very rare. So the patient will have anti-platelet antibodies, megakaryocytes in peripheral smear or in bone marrow. 3 to 5 per 100,000 population, that's what the usual prevalence is. Immunodestruction of normal platelets, that's the mechanism. Immunosuppressive therapy should be the first line treatment and it shows the fastest response. So in such a patient who is not actively bleeding, who has got history of ITP, instead of giving platelets, we should be starting this patient on IVIG and steroids. What if such a patient presents with life-threatening bleeding? So what should we do then? Some sources say that we should not hold IVIG and steroids. We should give it concurrently with platelet transfusion. But platelet transfusions in an active bleeding, in a life-threatening bleeding is the first line of treatment. Excuse me, please. So, what are the common adverse outcomes? Thrombosis, very common in ITP patients. Risk is particularly increased if the patient's platelet counts are more than 20,000. Volume overload. Like I told you, in such patients, if they have pre-existing conditions like congestive heart failure or pulmonary edema, volume can lead to disastrous consequences. I'm sorry. Thrombosis. It becomes a vicious cycle. If we keep on, what happens is we start these patients on platelets, the platelet count goes up, then there is a significant risk of thrombosis. Then we have to start these patients on anticoagulation. Anticoagulation then increases the risk of bleeding. So it becomes a vicious cycle. How to prevent that? We need specialist help in that, but there is something called thrombopoietin receptor antagonists, which are usually used in such circumstances. I'm sorry, I'm having some cough. Okay. Thank you. Let's talk about case 5 here. 75-year-old female patient with stroke, right hemiplegia, seizures, pneumonia. The patient is intubated. Patient receives antibiotics, diuretics, sedatives, anticonvulsants, and unfractionated heparin. Patient is extubated, transferred out of ICU on day 7. Valproic acid and lorazepam are added to Keppra. The patient's platelets fall to below 50,000 on day 17. So 10 days after the patient was transferred out, the platelets have fallen to 50,000. There is a score called 4T score. I'm not going to go into details of that 4T score, but it's usually used for suspected HIT. I will come back to the 4T score a little while, let me just do this thing right now. Okay, I'll come to the 4T score later. 4 points gives us intermediate risk in this patient. 0 to 3 is low risk. 4 to 6 is intermediate risk, and more than that is high risk. Antiplatelet factor 4 and heparin IgG are negative. So we got this lab result, it was negative. What should be done next? So the answer is very clear. We started noticing the drop in platelets once we started this patient on valproic acid. Sodium valproate is known to cause thrombocytopenia, either immunologically or non-immunologically. So drug-induced thrombocytopenia is a very common thing which we usually encounter. How to differentiate between, let's go to the next slide. So you see here, the valproic acid was started, and as soon as it was stopped, when the platelets reached the nadir, right there, the platelet counts steadily creeped up. Now if you would notice that, even when the valproic acid was started, the platelet count decline was slow and steady. It was not an abrupt like this. It's important. I'll tell you why it's important. Because in immune drug-induced thrombocytopenia, we expect the platelet count to decrease rapidly. In non-immune causes like, for example, bone marrow toxicity, we expect the count to fall down slowly, not very rapidly. The majority of the cases we see in internal medicine wards are of the non-immune variety because there is direct suppression. All right. So if the patient has immune and is, if we have verified that the patient has drug-induced immune thrombocytopenia, then the patient will require IVIG. No steroids, IVIG only if bleeding. Last case. 78-year-old female who is received a percutaneous intervention and has an instant thrombosis. She's on aspirin and Plavix, goes into cardiogenic shock, is resuscitated. Coronary angioplasty is performed on this patient. Unfractionated heparin drip has been initiated when the patient came to the hospital. Platelet count has dropped from 300,000 to 28,000 on day 5. Now this is very important. Look, the platelet count has dropped on day 5. The unfractionated heparin drip was started as soon as the patient came in. Take a look at this graph here. So we had coronary angioplasty here. this was the platelet count on arrival, mild thrombocytosis here, then unfractionated heparin and therapeutic dose started. Can you see this decline right there? This patient had HIT, heparin-induced thrombocytopenia. The enzyme immunoassay of IgG was positive. The heparin-induced platelet activation was positive. So heparin was stopped here. Once we have the positive assays here, the heparin was stopped. But you see that the platelet count is not going up the way we would have expected it to go up, right? Why? Because there is HIT is usually associated with some other form of process which is causing thrombocytopenia in addition to heparin-induced thrombocytopenia, most of the times. What's the usual critical care course of the platelets? The critical patients usually have a biphasic course. There is an initial dip, goes down, in 2 or 4 days it reaches in the nadir, and then it slowly creeps up again. What if the patient has progressive thrombocytopenia? Is it rapid? Think of immune causes. In any rapid decline of platelets, think of pseudo thrombocytopenia or immune causes of thrombocytopenia. Slow, consider infection or bone marrow toxicity like we discussed in the previous case. Now we come to 4T score. I had just mentioned to you what the 4T score is. I am not going to go into detail, but it covers these 4 aspects: thrombocytopenia and the platelet count fall, less than 50%, 30 to 50%, and less than 30%. So we give 3, 2, 1 points to each of them. Maximum number of points we can have are 8. Timing of the platelet count fall is taken into consideration. Thrombosis like skin necrosis, skin thrombosis, that's taken into account. And other causes, for example, if we have a definite cause of thrombocytopenia, then it's 0 point. If the patient has 0 to 3, 4 to 5 is intermediate, and 6 to 8 is high. Low, we can possibly say that the patient likely doesn't have heparin-induced thrombocytopenia, but in 4 to 5 and 6 to 8 we should get the test done, because that heparin-induced thrombocytopenia is not a risk for bleeding, it's a risk for thrombosis. So we need to start these patients urgently on a non-heparin anticoagulant. That's why we need to get these results as early as possible. This can just guide us. Ultimately, it's going to be our clinical judgment. I think we order HIT in every single patient. So 5 to 14 days after using heparin, IgG antibodies are assayed. They are against the antiplatelet factor 4 or polyanion complexes. They activate platelets via Fc receptor and they generate thrombin. So that's the reason why it's prothrombotic, right? Other mechanisms can still contribute. Remember, if you have diagnosed HIT, it doesn't mean that the patient will not have thrombocytopenia because of any other cause. The patient can still be critically ill, can still be on a medication like a diuretic or valproic acid or antineoplastic medication, and that is causing thrombocytopenia like we saw in the previous graph. The counts were going up steadily. They were not even going up steadily, they remained right in the lower range in that graph. So antibodies of HIT, they usually disappear in 50 to 80 days, but re-exposure is a very common phenomena, and if the patient is re-exposed, the platelet count dip is going to be very abrupt. It can happen very suddenly. Platelets will usually fall below 20,000 in very rare patients. It's about 10 to 15%, but it's rare. Major mechanisms. We have already spoken about, we have, pseudo thrombocytopenia. We know what pseudo thrombocytopenia is. We know where to expect hemodilution, platelet consumption, sequestration, platelet production and destruction. This, there are a few other conditions besides the common conditions which we spoke about, and there are few clinical cues we can get from those conditions so as to identify them. Let's quickly go over them also. So, where can we see a decline in platelet consumption? Blood loss, bleeding, anemia, that's one of the commonest causes, right? So, there is nothing I need to talk on that. Massive trauma, how do we find out if the patient might be having a consumptive thrombocytopenia here? History and physical, radiology. Disseminated intravascular coagulation, very commonly seen in critical patients. Patient will usually have shock, infection. The patient will have prolonged clotting times. There will be an increase in fibrin degradation products. Patients may have nucleated RBCs on peripheral smear. So remember, disseminated intravascular coagulation is a common cause. Sepsis. Now the sepsis criteria, we have already spoken about that. There is an extracorporeal circuit, so there are areas of, we have to identify if the patient is on such a circuit, are there any areas of stress which is causing increased consumption of platelets? And if so, we can easily get rid of those areas. Decreased production. Where do we see decreased production? Intoxication. If the patient is intoxicated, the patient has been consuming a lot of alcohol, the patient is on drugs, yes, production has been decreased. Viral infection, HIV, hepatitis C, Epstein-Barr virus, cytomegalovirus, these are commonest viruses which cause decreased production. I have not mentioned autoimmune disease, so autoimmune diseases are also there. Bone marrow infiltration by leukemia or tumors, radiation. Find out, we can get history. We can find out if the patient has received radiation and that has caused decreased production. Chemotherapy, right? So, where do we see destruction? Immune, drug-induced, heparin-induced, TTP. TTP is another thing which we should be worried about in critical patients. We usually see what? Schistocytes, elevated LDH, renal symptoms pointing towards hemolytic uremic syndrome, negative direct Coombs step. Patients may have, obstetric patients might be having HELP syndrome. You know what HELP is, right? Post-transfusion purpura. So how to diagnose that? I think it's a little rare. I have not seen much patients in this hospital. History, anti-HPA1A antibodies will be positive. Passive or alloimmune is multiparous donors. You see that in them. Now, transfusion in critical patients. It's important that we have identified the common causes. Let's talk about transfusion. Like I told you in the beginning, the evidence of this is very low to low, and the strength of recommendation is weak, and the best I could see was moderate. So, the most of it will depend on your clinical judgment. Always look at whether the patient is actively bleeding. Don't look at the platelet count. Look at the patient first. So that's the main thing. If the patient has ITP, DITP, HIT or TTP, you have diagnosed either one of these conditions, then you see if the patient is actively bleeding or not. If the patient is not actively bleeding, and even if the patient has thrombocytopenia, should we be giving these patients platelet transfusion? The answer is no, we should not be giving them. We should be giving platelet transfusions in these conditions only if the patient has life-threatening bleeding. So, in normal bleeding in critical patients, WHO grade 2 is more than a little mild. So, World Health Organization has a few grades of bleeding. So, grade 2 is like, epistaxis, melena, these kind of things. A higher grade becomes a major loss, and grade 4 is massive blood loss. What is wet purpura? In wet purpura, we transfuse platelets. Wet purpura is patients who have been in intensive care unit for a long time, transferred out, have been oozing blood from their gastrointestinal mucosal membranes. That's what is wet purpura. So if the patients have such kind of a thing and the platelet counts are critically low, we should transfuse platelets in these patients. It helps. So if the patient now, some weak evidence on if we are anticipating bleeding, that there is a patient whom we think the patient is going to start bleeding anytime now. What's our threshold? It's 20,000. So if the platelet count is less than 20,000, we start transfusing these patients with platelets. What is the threshold in sepsis? Like in any other patient, it is the only indication which has got moderate strength and some evidence. If the platelet counts fall below 10,000 in any patient, we should give platelet transfusion. That's what we usually do, right? So in sepsis patients, it's very important that we start transfusing these patients at the level of less than 10,000. Prophylaxis, I'll talk about prophylaxis, but there is very less data about use of platelet transfusions for prophylactic purposes. So this I have gathered from different sources and the article Dr. Marion gave me. So the number one thing, adult patients with platelet counts less than 10,000, moderate strength, evidence that we should transfuse platelets. Other scenarios like a central venous catheter placement, we usually transfuse platelets if the platelets are less than 20,000. Elective lumbar puncture, 50,000. Urgent lumbar puncture, 20,000. Now, these are all numbers which have come from low quality evidence, and we have to use our clinical judgment at that point of time whether to give these patients platelets or not. Major elective surgery, same as elective lumbar puncture. Let's bring the platelet count to 50,000 before we proceed for surgery. Now, patients with intracranial hemorrhage and patients on antiplatelets, patient is going to have a neurosurgery the patient is not bleeding but is going to have a neurosurgery. We don't give platelets. There are no platelets to be given in these patients. All right. So I think, I may have done it a little quickly. Now, got one more slide left here. So, was the transfusion successful here? Expected rise, like I mentioned in the beginning, the expected rise should be about 15,000. But here is a patient who is very sick. Here is a patient whose normal homeostasis has been completely disturbed. Can we expect in such a patient that if we give platelets, it will rise by 15,000? Have you ever seen it? No. We usually do not get this. There is blunted response in critical patients. So what do we do then? We transfuse 2 units and we look for a rise. If the rise is there, that means our platelet transfusion is successful. If the platelet counts do not rise, even after that, look at the platelets we gave were ABO compatible or not. I'm pretty sure it's not even an issue here, but in certain instances it has been discovered that the platelets were not ABO compatible. Despite of the ABO compatibility, if the platelet count doesn't increase, then we should look for HLA antibodies and make sure that they are not present in the donor blood, because if they are present, that will not allow the platelets to rise as expected. All right, I guess that's it. So we have come to the most painful part. I'm sure none of you have any questions there. But if you do have any questions, so we have this gentleman sitting right here to answer all your questions. So, but in any case, if you have any questions, please tell me. Okay. Thank you so much.